Good morning and welcome to today's webinar. My name is Dave Edwards and I am the Chief Deputy Director here at OEHA. I'm really excited about the set of speakers that we have today. So this morning's webinar is the third in a series of webinars the Office of Environmental Health Hazard Assessment, or OEHA, is hosting as part of our efforts to track and report on climate change and its impacts on California. Each webinar in this series provides a synthesis of current scientific understanding on the featured topic and examples of actions underway to address the impacts. These examples are a small fraction of the work across California to develop and implement sustainable, equitable solutions to the challenges posed by climate change. Our last Indicators of Climate Change in California report demonstrates the importance of collaboration and partnerships in understanding and tackling the climate challenges that confront us. It is in that same spirit of collaboration and partnership that OEHA is convening these webinars with our state agency partners. Each webinar is an opportunity to strengthen partnerships between OEHA, our co-conveners, and the organizations represented by our speakers. Each webinar also presents opportunities to learn about areas of climate science or climate action that may be new for some participants. OEHA is grateful for these opportunities, and we'd like to thank Cali PA Secretary Yana Garcia for her strong support of this work. I'd also like to thank our colleagues at the Infectious Diseases Branch of the California Department of Health for planning and convening today's webinar with us. Climate change can create conditions such as warming temperatures and shifting wind patterns that allow insect vectors and the infectious agents they transmit to proliferate. This morning's speakers will discuss examples of infectious diseases influenced by climate change, along with the monitoring and surveillance and prevention efforts aimed at protecting Californians from these diseases. I'll now turn it over to Carmen Milanes, who will be facilitating the webinar today. Carmen.
Thank you, Dave. Good morning, everyone. I am Carmen Milanes, and I oversee the Climate Change Indicator Program at the Office of Environmental Health Hazard Assessment. And I'm joined today by members of that team, Tamara Cutter, Bennett Locke, Lori Montserrat, and Emma Tanner. As Dave mentioned, we are pleased to have our colleagues at the CDPH Infectious Diseases Branch to present information on infectious diseases influenced by climate change. So before we begin, I just want to go over some logistics for this morning's webinar. If you have questions for the speakers, please enter them in the Q&A box. We have requested our speakers to type in responses to questions as they're able to, but we have set aside some time following the 3 presentations for questions and answers. We will try to get to as many questions as we can, both from the Q&A panel as well as from those of you who would like to speak. If you do want to ask a question verbally, please raise your hand and wait for us to unmute you. Do recognize, though, that we have limited time and may not be able to get to all of the questions. So with that, I will turn it over to Dr. Duke Vuja, Chief of the CDPH Infectious Diseases Branch. Duke?
Thank you, Carmen and OEHA, for inviting us to this webinar, and good morning, everyone. I'm Duke Vuja, Chief of the Infectious Diseases Branch in the Division of Communicable Disease Control of the CDPH Center for Infectious Diseases. My branch oversees the surveillance and investigations of over 50 infectious diseases and conditions, including foodborne, waterborne, vector-borne, zoonotic, and emerging infectious diseases. Some of these diseases are affected by climate factors resulting from climate change, including increased air and water temperatures, earlier and prolonged summer heat and drought, river rainstorms and floods, and people and animals and vectors adaptations to these climate factors. For this webinar, 3 subject matter experts from my branch will be presenting on some of these infectious diseases affected by climate change. Dr. Andrea Lund will present on mosquito-borne diseases. Gail Sondermeyer Cooksey will present on valley fever, also known as coccidioidomycosis, and Sarah Rutschmann will present on Legionella and Legionnaire's disease. I will now turn the mic over to Carmen to introduce our first presenter. Carmen?
Thanks, Duke. We will start with Dr. Andrea Lund. Andrea is an epidemiologist in CDPH's vector-borne disease section. She leads projects focused on climate change, health equity, and data modernization as they relate to the surveillance and control of vector-borne diseases in the state. In October of 2023, she was involved in the investigation of the first locally acquired cases of dengue reported in California. Andrea?
Thank you, Carmen. I'm excited to be here and talk about climate change and mosquito-borne diseases in California. We have several different mosquito-borne diseases, otherwise known as arboviruses, in California that fall into two main groups. The first includes West Nile virus and St. Louis encephalitis virus. These viruses are transmitted by Culex mosquitoes, which are endemic to California. The second group includes dengue, chikungunya, and Zika viruses. These are typically associated with international travel and are transmitted by Aedes mosquitoes, which are invasive to California. It's important to think of these groups separately because the ecology of the mosquitoes differ. And because of those differences, we approach their surveillance and control in different ways. And climate is important for mosquito-borne diseases because changing patterns of temperature and precipitation affect the life cycle of the mosquitoes themselves. Adult mosquitoes lay eggs in water, and after they hatch, the immature stages of larvae and pupae develop in water before they emerge as the next generation of flying and biting adult mosquitoes. Changes in temperature alter physiological processes in the mosquito that affect disease transmission, including how often they bite, how quickly they develop from one life stage to the next, and how quickly the virus can replicate inside them. Precipitation also impacts immature stages of mosquitoes, but in more complex ways. Too much rain can wash mosquitoes out of their aquatic habitats, but too little rain can mean those habitats dry up entirely. West Nile virus is the biggest arboviral threat in California. It was first detected in 2003 in the state and has caused disease in people every year since. As I mentioned earlier, this virus is transmitted by Culex mosquitoes that are endemic to California, and they can be found in both rural and urban areas. An important feature of West Nile virus transmission is that it primarily circulates between birds and mosquitoes, which is important for how we approach surveillance. Infections in animals like people and horses are incidental. We are considered dead-end hosts because we don't develop enough virus in our bloodstreams for mosquitoes to get infected when they bite us. Most infections of West Nile virus in people have no symptoms, but symptomatic illness can range from mild febrile illness to serious and even fatal neuroinvasive disease. This is a graph of West Nile virus infections each year since it was introduced in 2003. You can see symptomatic cases in purple with neuroinvasive disease in the darker purple and non-neuroinvasive in lighter purple. We also have asymptomatic infections illustrated in gray, which are typically reported by blood banks. In 2003, over 400 cases of symptomatic disease were reported statewide, 3/4 of which had a neuroinvasive clinical presentation, and a small number of those cases were fatal. Human cases last year were about double the average of the preceding 5 years, but as you can see from here, is on par with the early years of neuroinvasive cases in California. Geographically, we find West Nile virus across most of the state. In 2023, 43 of California's 58 counties had West Nile virus activity reported. Most of those had human cases, which are counties shown in blue, though a few had environmental activity only, which are shown in green. Los Angeles was the county with the highest number of cases at 60, and Yolo County here in the Sacramento Valley experienced the highest incidence with over 17 cases per 100,000 people. As I said earlier, the bird mosquito transmission cycle is important for our surveillance, and that allows us to detect West Nile virus in a number of ways. Over 70 mosquito and vector control agencies conduct routine surveillance throughout the state. They trap Culex mosquitoes and test them for virus. They also contribute to the dead bird program at CDPH. Birds like crows and jays are particularly susceptible to West Nile virus, so finding a dead bird may be a sign of West Nile virus circulating in an area. And CDPH runs a call center for the public to report dead birds, and the local vector control agencies can pick up birds that are reported and submit them for virus testing. A third approach to environmental surveillance is sentinel chickens. Some agencies will keep flocks of chickens and monitor them for antibodies to West Nile virus. In 2023, vector control agencies detected West Nile virus in 4,522 mosquito pools, 857 dead birds, and 186 sentinel chickens. The environmental surveillance program also extends to an historically endemic arbovirus that has recently reemerged. Like West Nile, St. Louis encephalitis virus is transmitted between endemic Culex mosquitoes and birds, and in people it causes a clinically similar disease as West Nile virus. The first recognized outbreak of SLE was documented in 1937. It was detected annually after that, causing nearly 600 cases in people in California until 2003 when West Nile virus was introduced. After that, SLE completely disappeared, even though environmental surveillance continued and even increased during that time. It went undetected in California for over 10 years until 2015. It reemerged in Riverside County, first detected in mosquitoes and then in sentinel chickens. Since then, SLEV has been detected in a total of 23 counties. This includes 19 human cases reported in 9 counties last year. And environmental detections from 2023 also include 728 mosquito samples that tested positive, which is a record post-emergence, as well as 1 sentinel chicken. All this environmental surveillance helps vector control agencies assess risk and plan their operations accordingly. This is an illustration of a risk model that agencies use to summarize arbovirus transmission risk. It accounts for temperature, abundance of Culex mosquitoes, mosquito infection rates, as well as infection in sentinel chickens and dead birds. The model includes threshold values for each of these 5 dimensions, which are then averaged into a single overall estimate of risk. The value of the overall risk level then helps agencies determine what activities are needed in what parts of the jurisdiction. And here's a map illustrating risk level estimates in late September of last year. You can see that the gray outlines are the boundaries of the mosquito and vector control districts, and the colors within those boundaries vary by risk level. Yellow areas reflect normal season conditions and let agencies know that routine activities are appropriate. Orange reflects areas that require more attention in terms of emergency planning. This might include enhanced surveillance, control, and outreach, as well as preparation for further escalation and risk. Red areas reflect epidemic conditions and the need for broader response, which may include communication with the media and medical communities, as well as further broadening surveillance and control activities. You may have noticed this pocket of orange and red down in the southern Central Valley, which reflects elevated mosquito abundance that followed extreme weather events during the winter of 2023. And this, you may recall news coverage from California about this time last year about a zombie lake. The Tulare Basin had been dry for decades with its water diverted for agriculture in the Central Valley. With heavy rains from a series of atmospheric rivers in the winter of 2023, the lake bed flooded again and created a body of water the size of Lake Tahoe. And this satellite image shows flooded area in early May when snowmelt was still coming down from the Sierra Nevada. With this new water source came an enormous habitat for mosquitoes to lay their eggs and for immature mosquitoes to develop into flying adults. Local agencies reported trapping far more mosquitoes than usual, and they also detected virus in mosquitoes from this area, but at rates that were not out of the ordinary. So this risk model is part of our surveillance and response plan for mosquito-borne diseases in California. You can download the response plan and lots of other resources at westnile.ca.gov. Now I'll shift to Aedes transmitted diseases, which, as I mentioned, are associated with international travel. Unlike West Nile virus, dengue, chikungunya, and Zika viruses are transmitted in a human mosquito cycle, and Aedes mosquitoes are found in mostly urban areas. These mosquitoes like to breed in water-filled containers like bird baths or the saucers under flower pots, and are often found in and around people's homes. Aedes mosquitoes prefer to bite people, and unlike Culex mosquitoes, which bite at dawn and dusk, they tend to bite aggressively during the day and can be a real nuisance in people's backyards. The human mosquito cycle of Aedes transmitted viruses makes it hard to detect the virus in the environment like we do for West Nile virus, but we keep track of where invasive Aedes mosquitoes are. They were first detected in California in 2011 and have since become established in many parts of the state. As of the beginning of May, 24 counties have detections of invasive Aedes mosquitoes. And these viruses are transmitted primarily by international travel and vary in the number of cases that are reported from year to year. In 2016, Zika eclipsed dengue and chikungunya with over 500 cases, but Zika cases have significantly dropped off since then, with only 3 cases reported in 2023. Dengue has since become the dominant travel-associated arbovirus, with 231 cases reported last year. And I'll focus on dengue from here on out since it's for its dominance recently. And this is the same case data here. Between 2016 and 2023, we've seen an average of 148 cases of dengue per year, and all of those have been travel associated except for 2. So in October and November last year, 2 locally acquired cases were reported in Los Angeles County. And travel history for dengue cases tends to be to areas of South and Southeast Asia, as well as Latin America, where dengue incidence is relatively high. And reports of dengue in California fluctuate seasonally. They tend to peak in late summer with an average of 33 cases with symptom onset in August. And because our environmental surveillance is limited, we tend to first learn about dengue activity through human case surveillance. That means someone who feels sick after returning from a trip, go to the doctor and they'll get tested. If a test is positive, the local health department will receive those results and follow up with the patient to determine if they meet the criteria of the case definition. The case definition includes clinical, laboratory, and epidemiologic criteria. Laboratory results are most often from serological testing, which can be challenging to interpret because the antibodies we produce to fight arboviral infections often cross-react. So positive serology with one virus could be due to infection with another one. And so a patient with a positive serology and no travel history is kind of a puzzle for us. We have to figure out whether their illness is due to rare local transmission of a travel-associated arbovirus like dengue, or the simpler explanation is oftentimes that it's just an endemic arbovirus like West Nile. So this is the position we were in last fall when we began investigating these locally acquired cases of dengue. And I'll walk through very briefly through the timeline of one of those cases. So in early October, the Pasadena Health Department received a lab result for a resident who had no travel history but tested positive for dengue antibodies. So we thought West Nile virus was the simplest explanation, likely, but out of an abundance of caution, the local health department notified their vector control district of a possible dengue case. The San Gabriel Valley Vector Control District immediately began doing mosquito surveillance in the neighborhood and found 4 times the number of Aedes aegypti than usual. They followed that up with mosquito control activities and reduced the number of adult mosquitoes. And while the Vector Control District responded, the local health department pursued additional testing at the Viral and Rickettsial Disease Laboratory at CDPH, and those lab results confirmed dengue infection. So that mosquito surveillance and control by San Gabriel Valley was ongoing from when they were first notified by the health department. For guidance from CDPH, they conducted weekly surveillance in the neighborhood targeting Aedes mosquitoes. That involved inspection of 141 properties for water-filled containers and required treatment of 121 of those properties. They also engaged in extensive communication with the public. So a number of conditions have to align just right for local transmission like this to occur. A viremic traveler first needs to return to a region where there are invasive Aedes mosquitoes, so one of those 24 counties in California where they've been detected. And then they have to be bitten by one of those mosquitoes that goes on to live long enough to become infective and bite another person. Last fall, another extreme weather event, Tropical Storm Hillary, helped to create conditions for local transmission like this to happen. August in Southern California is usually hot and dry. Temperature is suitable for mosquitoes, but the lack of precipitation limits the habitats available to human-filled water sources such as bird baths and flower pots. But as Hillary came through the area, it brought over 2 inches of rain to downtown Los Angeles in a single day and broke rainfall records that had stood since the 1870s. This rain inevitably filled other containers on the landscape, and Aedes mosquitoes can take advantage of containers as small as a bottle cap like this one you see here, which is full of larvae and pupae. With this rare infusion of water, it is easy to see that why the vector control district found so many more Aedes mosquitoes than is typical for that time of year. A larger mosquito population biting voraciously during the day in a populated area that receives a lot of return travelers created conditions that align just right for local transmission. But dengue incidence is increasing globally right now, particularly in Latin America, and it is likely to increase as the climate warms, primarily through increased transmission in currently endemic areas, so those tropical parts of Latin America and Southeast Asia, but secondarily through the expansion of the geographic range of Aedes mosquitoes. Globally, an additional 2 billion people are predicted to be at risk of dengue in 2080 compared to 2015, which would bring the total population at risk to over 6 billion people globally. This means we are likely to see an influx of travel-associated cases in California and more opportunities for Aedes mosquitoes to pick up viruses from returned travelers and pass them on to people who haven't traveled. The global situation makes our surveillance and response to invasive Aedes mosquitoes and the viruses they transmit all the more important. And this system depends on communication and coordination between local health jurisdictions, vector control agencies, and CDPH. Local health departments communicating with vector control on suspicion of local transmission is essential for a timely response, as occurred in Pasadena. And in turn, the vector-borne disease section provides support to their local partners and facilitates broader medical, laboratory, and communication support at CDPH. And all agencies are guided by a response plan for Aedes transmitted diseases that is available on the VBDS website. In summary, mosquito-borne diseases are impacted by our changing climate. Rising temperatures alter the physiology of mosquitoes in ways that increase their ability to transmit viruses, and changing patterns of precipitation can also increase mosquito activity as well as risk for arboviral transmission. Extreme precipitation events in 2023 led to unusual activity, though extreme drought can also serve to promote West Nile virus by concentrating mosquitoes in fewer habitats and increasing their contact with birds. All these impacts underscore the importance of continued surveillance and response to mosquito-borne diseases in collaboration with our local partners. And as West Nile virus and dengue differ in their environmental characteristics, so too do they differ in their equity considerations. Because Culex mosquitoes are present in both rural and urban areas, we are concerned about the disproportionate exposure of outdoor workers, including farm workers and landscapers, to West Nile virus. On the other hand, the risk of local dengue transmission may be higher in lower income areas of cities because of higher abundance of invasive Aedes mosquitoes compared to more affluent areas. What's common among all mosquito-borne diseases, however, is that our surveillance relies on patients seeking healthcare when they get sick. We acknowledge that our current systems do not capture cases in vulnerable Californians who are either uninsured, underinsured, or otherwise unlikely to see a doctor. We are working to develop systems that capture cases in these populations and working with partners to alleviate their disproportionate exposure. I'd like to end by acknowledging my colleagues at CDPH, as well as the local partners who conducted the on-the-ground investigations of the locally acquired dengue cases. Our work is a team effort, and I'm happy to take any questions.
Thank you so much, Andrea. It's great to see the ability of the department to work very closely with your partners to not only keep an eye out in terms of surveillance, but also be prepared to respond and take whatever necessary actions to help make things not quite as so bad as they could potentially be. So with that, I would like to introduce our second speaker, Gail Cooksey. Gail is an epidemiologist in the Infectious Diseases Branch of CDPH, and her work focuses on conducting surveillance, outbreak investigation, and provider and public awareness efforts for mycotic diseases, particularly this one, the topic of her talk, valley fever. Gail?
Great. Thank you so much, Carmen, and thank you all for having me to speak today. As Carmen said, I'm going to be speaking today about a disease called coccidioidomycosis or valley fever, and the role of climate and environment in the increases in the expansion that we've been seeing of this fungal respiratory disease in California. So to start, really basically, valley fever or coccidioidomycosis, we realize is something that not everyone is familiar with. And it's a fungal respiratory illness that's caused by breathing in spores of a specific fungus from outdoor dirt and dust. And it causes symptoms that are very similar to other respiratory diseases, such as influenza, COVID-19, or bacterial pneumonia. And in California in recent years, we've seen about 7,000 to 9,000 cases, and a lot of recent expansion and increases that I'll mention today. But consistently, we do see the highest rates of this disease in Central California, specifically in the Southern San Joaquin Valley, which is where valley fever gets its name. And as a respiratory illness, a lot of the symptoms of this disease are listed here on this slide, and they're common symptoms that you'd see, as I said, with influenza or COVID-19. But in comparison to those diseases, the symptoms of valley fever can often last for months or even years. And they can be severe, they can be chronic, or even lifelong, and they can also be fatal. Unfortunately, diagnosis for this disease is quite challenging. As I've already mentioned, it has this non-specific presentation that looks a lot like other diseases that are much more well-known. But in addition to that, the laboratory results can be quite hard to interpret. And the providers are not always familiar with valley fever diagnostics, particularly if these providers were not trained in a high incidence area, such as the state of California or the state of Arizona. And because of some of these challenges, we see some major delays in diagnosis of this disease. And in one recent study that we did, we found that there was a median of 27 days from the time that a patient first got symptomatic with valley fever to the time of their testing. So there's a really big delay in valley fever diagnosis. There is management available, but mild cases will often resolve on their own. Severe disease does typically need to be treated. And then if someone develops meningitis, that actually requires lifelong treatment. Unfortunately, prevention is also challenging with this disease. Part of the reason for this is it has a low infectious dose. So inhaling just a single spore or a few spores could cause infection. So this is very hard to prevent, and our messaging does focus on just generally reducing dust and dirt exposure. But unfortunately, at this time, there's no vaccine, although there are some trials currently being conducted for a valley fever vaccine in dogs. We see some major disparities and issues of increased risk of valley fever that I wanted to touch on. This data on this slide is the median annual age-adjusted rates in California from 2000 to 2018. A little out of date, but a lot of these disparities still hold today, where here you see that we have about double the rate in males than we do in females. We see really high rates in kind of the working age population, as well as older populations. And then in terms of race ethnicity, it's quite well known that Black or African American populations have increased risk of severe disease, but we also see increased rates in Hispanic or Latinx populations. In addition to that, we also see some increased risk in basically anyone who has exposure to outdoor dust or dirt in high incidence areas. And this does include outdoor workers. And this is a population where we have seen repeated outbreaks of valley fever. So outdoor workers where we've seen outbreaks, including construction, wild and firefighters, military, and there is concern that there's also risk among agricultural workers. Now, this map here shows where valley fever is endemic. It is endemic in southwestern United States with over 97% of cases in Arizona and California. Other states where it's endemic are listed here, and then outside of the US, it's only also found in Mexico and parts of Central and South America. But it is likely expanding. And this was a study that was done modeling valley fever surveillance data with climate data and climate prediction data. And as you can see in the map on 2007, it still fits that southwestern endemicity that I had mentioned. But it looks like by 2095 that this could expand to be a disease that goes to much of Middle America. Within California, the highest rates, as I had mentioned, are consistently in Central California, and about 63% of our cases occur in just 7 of California's counties. And in 2019, as an example, we had 9,000 cases in California overall, and that's a rate of 22.9 cases per 100,000 population. But if you look at Kern County specifically, the rate there was 372 per 100,000 population. In terms of trends, they're kind of curious with valley fever because we've regularly seen these peaks and dips in cases over time, although we have seen some dramatic increases in recent years. We've also seen quite substantial expansion in California. So the map on the left is 2001, where the counties are colored by the rate of disease. The darker the blue, the higher the rate. And you can see in 2001, really Kern County lights up as well as the San Joaquin Valley. But by 2022, you can see how much more of the state of California is now lighting up in those blue colors. Southern California, the coast, the Central Coast, and moving up into the northern San Joaquin Valley. So, of course, the causes of this are not entirely understood, and it's very likely multifactorial. But listed on the slide are some of the things that we think about that could drive increases in expansion. I'm going to focus mostly on the first two, but we also consider that there could be more soil disturbing activities happening. There could be more susceptible people moving to endemic areas or traveling through endemic areas. And then it's always possible that we're seeing more valley fever just because it's getting recognized more or reporting more often. But as I said, I'm going to focus today on the first two here. Why and how is coccidioides, the fungus that causes valley fever, influenced by the environment and climate? So this animation shows how Cooksey is transmitted. So the spores of the coccidioides fungus live in the dirt and soil in endemic areas. When the dirt or soil is disturbed by natural causes like the wind or man-made causes like construction, those spores get into the air and they can be breathed in by people or also animals and cause an infection in the lungs that can then move to other parts of the body. So coccidioides is a soil-dwelling mold. And in this diagram here, it's represented by those linked little brown kind of oval shapes as the spores. And since it lives in the soil, it's going to be impacted by a lot of different environmental and climate factors, sort of the more direct ones listed in the first thing here with precipitation and temperature, but also by these extreme events, such as droughts, floods, earthquakes. And then, of course, all of these factors are going to interact over multiple years, which can make it really difficult to understand valley fever trends and predict what might be happening. But there is one hypothesis in the world of Cooksey that's quite common, and it's called the grow and blow hypothesis, and I'm going to walk through that briefly. So in this hypothesis, the Coccidioides fungus is really good at surviving extreme heat and lack of precipitation. It can go deeper in the soil, and during that time, a lot of its competition dies off. Then when rains come back and we see decreased temperatures, the fungus can germinate. It's got very few competitors and lots of decomposing matter to provide nutrition. If after that things dry up again and the soil is disturbed, all of those new spores can be aerosolized. And we have observed for a while this increase in valley fever following droughts in California. So to walk you through this graph a little bit, the orange yellowish colors are degrees of drought in California. The darker the color, the more severe. And the higher it is on the y-axis is how much of California it covers, essentially. And then the black line are the number of valley fever cases by year and quarter. So you can see really clearly where we have these blue circles that valley fever peaks after droughts. And this could potentially make sense with this grow and blow hypothesis that I had mentioned. So we'd observed this for a while, but didn't really have analytic data to support this in a more convincing way. So we came up with a collaboration with UC Berkeley and other academics, and they had some great expertise to model our valley fever case data, our surveillance data, with environmental and census data sets. And their very first analysis that they did looked at the effects of precipitation, heat, and drought on valley fever. So they looked at our surveillance data at the census tract level and modeled it with different climate impacts. And what they found really supported what we had observed in these trends. So this diagram summarizes it. What they found was that when we see multiple years of drought, followed by a wet winter, followed by a hot summer, we see increases in valley fever, particularly in the fall. And again, this fits really well with that grow and blow hypothesis. And they also found that this effect was 36% stronger following 2 dry winters, the multiple years of drought. They also found that we have excess cases in the 2 years after a drought, not just 1, but in the 2 years after. And they found that in these big years, these increased years, we have a strong seasonal signal. So in this graph, we have the months of the year on the bottom and some of our top Cooksey counties on the y-axis. And the darker the color is the higher the incidence. So you can see here that in these increased years, we have low cases in the spring, and then things really seem to pick up in the late summer and fall. So after this paper came out, we very quickly had the opportunity to see this in real life. So in early 2023, we noticed that we had a wet winter following several years of drought. So based on these findings and our experience, we would expect that to be a large year in 2023 with a strong seasonal signal, low cases in the winter and spring, high in the summer and fall. So before we even started seeing an increase, we actually tried to put out some alerts based on the research we had. We started alerting the local health departments, providers, and the public in June 2023. And then lo and behold, we did see the increase that we had anticipated. So this graph, the gray kind of background bars are the total number of annual cases by year. And then the colored bars are the number of cases by quarter. And you can see where the black arrow is that in 2023, we had relatively low cases in Q1 and Q2. We started to see an increase in Q3 and then a very large increase into Q4. And we did end up with a likely record year of valley fever cases in 2023. But as I had mentioned earlier, the research that UC Berkeley did found that we have excess cases in the 2 years after drought. So that would mean that we would also want to be a little wary of 2024 and watching what could happen. Thus far, we did see a slight decrease from Q4 of 2023 to Q1 of 2024, but it is also the highest first quarter we've ever had for valley fever on record. And if we see this strong seasonal signal, we would kind of expect a drop off and then potentially another peak in Q3 and Q4. So Just to conclude, valley fever is a disease caused by an environmental pathogen heavily impacted by the environment and climate. But we're really just beginning to understand what some of these drivers are, and feel very lucky for the collaborations we have to look at this as far as we had. So far, we've seen associations with temperature, precipitation, and drought. And even that alone has a lot of climate change implications. With the anticipated increasing frequency of drought, that could mean that we'll continue to see expansion of valley fever and potentially more intense seasons. So from the perspective of the health department, I think some of our main action items are highlighted in this final bubble on the right. We want to make sure that we increase awareness of valley fever among providers and the public, improve and strengthen surveillance, continue researching drivers, and then improve diagnosis, management, and prevention of the disease. And then to end on a note that we were really excited about, in 2022, valley fever was listed as a California climate change indicator impacting human health by CDPH and OEHA. And this is not a disease that is very well recognized. And we were really appreciative for this opportunity to talk about valley fever and how it may be heavily impacted by climate change. With that, I will finish up. If anyone is interested in learning more, please go to our website, which you can get to by going to couldbevalleyfever.org. And then my contact information, as well as our media team, are listed on the slide. And thank you very much.
Thank you, Gail. It's rare that nature provides conditions that allow us to test hypotheses. So fascinating set of data there. Thank you. So our third and final speaker is Sarah Rutschmann. She is an epidemiologist and subject matter expert for Legionellosis with CDPH's Infectious Disease Branch and has been serving in that capacity since 2017. Sarah collaborates with federal, state, and local health partners to investigate outbreaks, improve disease surveillance, and enhance prevention and response activities. Sarah?
Great, and thank you so much for the opportunity to speak today, and I'm just going to get right into it. So today I'm going to be talking about Legionellosis, which is another pathogen covered by the Infectious Diseases Branch that we also expect to be climate mediated. So Legionella is a type of bacteria of which there are about 60 strains. And most cases of human disease, Legionellosis, are associated with Legionella pneumophilus serogroup 1, so one particular strain. And Legionella occur naturally in freshwater environments. They grow and multiply best in warm and stagnant conditions. So we think of about 77 to 113F as being the kind of real danger zone for Legionella growth. And Legionella also grow particularly well in situations where biofilm may be present. So, and just to sort of explain a little bit better about biofilm, biofilms are collections of microorganisms that stick together and they stick to surfaces, and they create a sort of slimy protective habitat that can shelter microbes from environmental hazards like disinfectants, drying, or heat. And so they really provide a supportive environment for microbial amplification. And so with that, there's really the potential for growth and transmission of Legionella within the built environment. Artificial water systems in particular can provide little, areas or outlets that support the development of biofilm, like, hard to reach areas and pipes. All right, so this figure here on the left, I like to include this. This is a figure courtesy of CDC that really kind of illustrates what I just described about Legionella and sort of their entry and amplification support within biofilm. And there are actually a lot of factors that can contribute to the growth of Legionella within water systems, including obviously temperature, presence of sediment or biofilm, water stagnation, disinfectant residual, age of the water, but also construction, water main breaks, or changes in water pressure. Some of these factors can end up dislodging biofilm that might have been, hidden in a pipe leg, but also changes in municipal water quality. So I like to explain transmission as a three-step process. So step one occurs when fresh water containing Legionella is introduced to an artificial water system or built environment, which again is really where we see colonization and amplification occurring. Step two occurs when aerosols are emitted directly from water fixtures or features that are connected to that contaminated system. So I've got some photos on the right, but think of, shower heads, sink faucets, hot tubs, devices that generate aerosols. Step three occurs when a susceptible person breathes in those aerosols or aspirates water containing Legionella, and that is when illness can result. And a quick note before moving on, exposure to Legionella via potting soil is also a recognized transmission mode, but it's far less common than the traditional exposure via water aerosols that we focus on. All right, so Legionnaire's disease is a severe pneumonia, and typical symptoms include fever, cough, and shortness of breath. The incubation period is 2 to 14 days, and it's a rather severe illness. About 98% of patients end up requiring hospitalization, and up to 44% may need intensive care. Unfortunately, about 10% of patients die, and mortality is actually higher among patients whose infections are healthcare associated. So most people exposed to Legionella do not develop illness, but risk factors include ages 50 plus, current or former smoking, chronic lung disease like emphysema or COPD, immunosuppression due to disease or medication, system malignancy, or other underlying conditions including diabetes, kidney failure, or liver failure. All right, so I want to take a couple of moments to talk about some national trends. And we'll talk about a few California trends as well. But nationally, the highest incidence of legionellosis is observed in parts of the Midwest and Northeast. Incidence in the West, including California, is significantly lower, and we're not entirely sure of the differences in these incidence rates. There are some clues maybe that we'll talk a little bit about later. But when we do Legionnaire's disease surveillance, what we try to do is focus on notable high-risk exposures. And so those, the kind of main surveillance buckets that we focus on include overnight stays in travel accommodations and healthcare facilities, as well as residents in congregate living settings. And the reason we focus on these aspects for surveillance is that people who have these stays or who live in these kinds of facilities are more routinely exposed to larger complex water systems that may provide the sort of supportive environment for Legionella growth. Okay, briefly on national seasonality. So nationally, cases of Legionnaire's disease peak during the summer months. So think, June through September, depending on the year. There are slight variations year to year. In California, we have seen a reported increase in cases of Legionnaire's disease starting in around 2000 through 2019. And there was an average of about 500 cases per year reported in California between 2017 and 2019, those years leading up to the pandemic. There were fewer reports of LD in California for most of 2020 and 2021, likely due to the COVID pandemic. But towards the end of 2021, we did start to see a real resurgence in Legionnaire's disease cases, as well as increases in outbreaks. So a little bit more about California trends. The majority of cases in California are reported by Southern California jurisdictions. So over 70% of cases statewide are reported by just 6 counties in California, those with the highest incidence. And you can see these are the counties represented in the darkest blue at the bottom. And importantly, these counties actually only represent 55% of California's population. So there really is, more disease and higher incidence being observed there. However, there have been large outbreaks that have occurred sort of outside these known hotspots, large explosive outbreaks in jurisdictions that really don't have a lot of experience responding to Legionnaire's disease. And incidence does appear to be rising statewide. So a majority of California cases are what we call sporadic. And what I mean by sporadic is that these patients don't report any sort of high-risk notable exposures like overnight stays in travel facilities, healthcare, or congregate living. And these cases are also not associated with a known outbreak. So roughly 2/3 of cases in California actually, we don't have a real clear idea of a likely exposure source. So it really leaves a lot of questions about what is, driving LD increases. And lastly, before I leave this slide, I want to note, you'll remember a couple of slides back, I was talking about national seasonality. So interestingly, in California, our seasonality differs. Our cases actually peak during the winter months of December and January each year. We do have a secondary peak in late summer, which does line up with national trends, but we still haven't quite figured out, why we see the highest number of cases during winter months. All right, so lastly, before moving on to talk a little bit more about drivers, I want to mention that there are observed racial disparities in Legionnaire's disease acquisition, and this trend holds at the national level as well, though the data displayed here are specific to California. And in these data, Black patients are overrepresented in our burden of Legionnaire's disease cases. So we have been trying to take a closer look at this with the help of a CDC Epidemic Intelligence Service Officer, Dr. Cassie Schember. And while we're still in the early stages of kind of investigating causes for this disparity, one notable trend seen so far is that both Black and Hispanic patients living in less advantaged neighborhoods, when we're looking at the Healthy Places Index, they account for a disproportionate share of sporadic LD cases, which again make up about 2/3 of all of our cases statewide. So with potential for increases in LD as a whole, and specifically sporadic cases, there's really the potential for equity implications with respect to climate change and its impacts on Legionnaire's disease. All right, so why are LD cases and outbreaks increasing? Well, it's likely multifactorial with a lot of factors at play. Improved provider awareness, diagnosis, and reporting are likely playing a role. It's possible that the increasingly susceptible population may just be providing a greater share of individuals who are at risk for LD acquisition. More patients of advanced age, more patients with immunocompromising conditions. Aging building infrastructure is an interesting one. This is one of the factors that we think may help to explain the difference between higher incidence in the Northeast versus the West, with the Northeast having just a larger share of older historic buildings and older plumbing as well as compared to the West. And notably, we also think that increased stagnancy during COVID-19, when a lot of buildings, were underused or unused, and just less water flowing through those water systems, could have created conditions to really amplify existing Legionella in the system. And so globalization, increased travel, again, more patients may be staying overnight in travel facilities. Workforce shortages in water management industries also play a role, and we're going to talk a little bit more about water management later. But all of those factors, we're thinking more about the role of climatic factors. And I should mention before going on that we really aren't terribly far along in our exploration of climatic factors, at least in California, on Legionnaire's disease. But it's something that we would really like to look into more, given some of the research and literature coming out from other places. All right, so let's talk next about some of the direct and indirect effects of climate change, potentially on Legionella growth and transmission. So I think the fairly obvious one is increasing temperatures. Right, you'll recall that Legionella really like warm environments, and increases to ambient temperatures could enhance microbial growth, including in cold water supplies or reservoirs. So if you think about a cold water reservoir that is then feeding out through a municipal system, there's really the potential for further downstream seeding or contamination events, as well as amplification within those built water systems. There's also the potential for increased Legionella growth in the soil, and increasing temperatures indirectly may increase the use of water aerosolizing devices in industry, community, and residential settings. I want to mention the photo that you see here on the bottom right of the slide is of a cooling tower. I'll explain briefly. Cooling towers are units typically used in an industrial setting or for buildings that might have advanced cooling needs that uses water to cool air. And these fans on top of the cooling tower units emit aerosols from the top. It's called cooling tower drift. And these aerosols can be contaminated, with Legionella. And cooling towers are a sort of commonly associated with Legionnaire's disease outbreaks, and they really can cause large explosive outbreaks. And so also with respect to potential climate change mediated factors, we get concerned about an increase in extreme weather events and natural disasters, both of which could result in flooding or contamination of artificial water systems and drinking water. So there are a number of other factors, and these are sort of interesting, related to potentially how long Legionella can survive in the air. Changes in precipitation, humidity, winds, and UV radiation patterns, all potentially affected by changes to the climate over time. So one example, and there are, I believe, some links to papers at the end of this talk if anyone's interested for further reading, but there's been a documented increase in sporadic cases observed after periods of increased rainfall or during warm weather where increased humidity was observed. And increased humidity and decreased UV radiation may allow Legionella to survive a little bit longer on the air. So when you think about a device that has kind of, emitted contaminated aerosols, the Legionella in those aerosols can only survive for so long, but changes to humidity and UV radiation may, permit that survival to last longer. And of course, the wind factors in particular affect movement or dispersal of those contaminated aerosols on the wind, resulting in either different or broader geographic areas being affected. And this point's especially important when we think about cooling towers that often sit on top of a building and kind of emit their plume into the air and affect a broader area. Lastly, there's also the potential for suppressive effects for Legionella associated with prolonged drought. To talk a little bit more about indirect effects of climate change, shifting patterns of water usage and sustainability, especially in drought-prone areas like California, could indirectly affect growth of or exposure to Legionella. So let's talk about some of these. So as we continue to see, drought patterns, we may continue to also see increased reliance on alternative water collection and storage methods. And sometimes these methods are done in a way where the environmental conditions are supportive of or permit contamination and or are favorable to microbial growth. We've seen an increase in use of reclaimed water, again, especially in drought-prone areas, typically used for irrigation, but this reclaimed water is not treated to the same level as potable water. So even if it's being used for irrigation, if it's, think about like a golf course or something like that, if these aerosols are still sort of, in the air and potentially exposing community members, it's important that water isn't treated to the same level as potable water. An increased use of low flow devices and fixtures to conserve water may increase stagnancy. So obviously, water conservation is a very valuable and important end. However, use of these devices, reduces the amount of water flowing through a water system and really does support a more stagnant environment that could support microbial amplification. So just two sides to some of these things. Increasing use of wastewater treatment plants is also of concern. I think there's been at least one paper that has connected cases of Legionnaire's disease to exposures emanating from a wastewater treatment facility. And lastly, increasing exposures to Legionella due to home composting or even larger composting facilities in communities. So I want to mention a few things about prevention. So for Legionella, our biggest tool that we use for prevention are water management programs. And these are plans implemented at the building level to really basically control for hazardous conditions supporting Legionella growth and transmission. And so this water management programs are a requirement by CMS for healthcare facilities. Outside of that, there really is no mandate either at the federal or state level for buildings to have water management programs. And so, really with limited public health resources, we have to prioritize the highest risk settings, buildings that have large complex water systems like hotels, congregate living settings, and buildings with cooling towers. And so the goal of these water management programs, of course, is to identify points within the water system that are susceptible to growth, as well as the points of aerosolization within these buildings, whether that be a cooling tower, whether this be a building with a lot of shower heads and other fixtures that generate aerosols. And so water management programs really focus on routine maintenance and remediation in these settings. So they really seek to make sure that aerosolizing devices that are attached to this water system are routinely cleaned and maintained, that these buildings undergo periodic flushing to reduce stagnancy in the water system. Temperature controls are also important to make sure that hot water tanks and so forth are set to control limits that don't really leave water in that danger zone for Legionella growth for too long. And lastly, water management programs may include considerations about secondary disinfection or point of use filters or controls, but these are really pretty detailed control measures that are mostly only seen in healthcare facilities. Right. And for long-term prevention, outside of a building-to-building water management program system, we're thinking about other ways that we could hopefully reduce Legionella growth and exposure over time. So we're thinking about whether a reduced reliance on water-based cooling systems like cooling towers could play a role. This is another thing where we're not totally clear on whether cooling towers are less common in California than in some other states that are not drought prone. It stands to reason that might be the case, but we need to take a closer look into that to see if that's the case. And there is a registry for cooling towers in New York City. There may at this point be a couple of other jurisdictions that have that. We have no such mandate in California. And so, we really don't know where cooling towers are located, and response to them really, unfortunately, happens more in an outbreak setting. So if cooling towers were registered and such a registry included requirements for routine maintenance, it would go a long way in preventing Legionella growth and hopefully outbreaks associated with cooling towers. We're also thinking about efficient design tactics to reduce aerosols and better use resources. So again, these are outside of our scope or purview, but things that industry can be thinking about to reduce aerosols and also better use resources. So think about drip irrigation for landscaping as compared to sprinklers that might be less efficient. We're thinking about the engineering of new buildings or renovations with prevention in mind. So choices of materials that decrease the potential for microbial growth in biofilms, for example, insulated pipes or temperature regulators for new buildings. And also thinking about designing water systems in a way that will prevent dead legs and backflow. And these are sort of technical plumbing terms, but these are both situations that can allow for Legionella growth and spread in a water system. And lastly, we're thinking about whether changes to disinfection or chlorination of public water supplies can help to mitigate Legionella growth downstream. All right, so to conclude, there are a number of direct and indirect effects of climate change that may result in increases to Legionellosis, and changing disease patterns and climate effects may play a large role. Immediate and longer-term prevention measures could reduce growth and transmission of Legionella, along with other harmful organisms, particularly within that built environment. And really, future studies and work specifically in California are needed to better understand the impact of climate on Legionella, specifically including exploration of things driving cases of sporadic disease. And lastly, it's important to better understand the racial disparities that have been observed, as well as understand other social factors that could increase legionellosis risk, because these are some of the communities that may be more vulnerable to the effects of climate change at large, and also as they relate to Legionella specifically. And I just want to acknowledge a lot of different data went into this, as well as specific colleagues that helped with this slide deck. And that's it. Thanks very much. And I'm happy to take questions afterwards.
Thanks, Andrea. There's a quick question in the Q&A about swamp coolers. Is that something you could address?
Yeah, that's a really good question. So we do the components for swamp coolers causing Legionella exposure are there. You know, they use water, they generate aerosols. I think the difficulty with swamp coolers is that, at least as I understand it, we're most often seeing those used in private homes. And so at least work in public health and response to Legionella, often we have to sort of prioritize resources on devices or settings that have the potential to affect broader swaths of the community. But we certainly have seen, you know, individual cases of Legionnaire's disease where maybe a patient didn't have any significant exposures except for a home swamp cooler. So we do think that that is something that could cause transmission, particularly within the home. And another interesting thing, I think, is that, you know, prevalence of swamp coolers, as I understand it, is you know, more common in some areas than in others. And I'm not exactly sure, you know, where they're the most common, but I've heard that from other colleagues as well, that, you know, maybe we don't see them in areas where it's cooler, but maybe a lot of communities in for more rural or Northern California areas may see them more. Thanks.
Okay. Thanks, Sarah. I would like to invite all of our speakers to turn their videos on, please. Thank you, everyone. Lots of excellent information. I would also like to invite our audience to raise their hand if they have a question that they would like to bring up, and be unmuted to do so. Right now, I don't see any questions in the Q&A panel. We've addressed what was there. But one of the goals of our webinar series is to figure out how to best communicate climate risk to relevant audiences. And I do see that communicating information through practitioners and local health departments plays a role in the work that you do at CDPH on infectious diseases. Could you comment some more on what you found to be effective, and how and what bits of the information are important to relay to the individuals who need to receive the message so that they can take action to prevent exposures or minimize, you know, not have the illness or minimize exposures? Would one of you like to take that?
Hey, Carmen, I can take that for valley fever. I think my talk today talked about some of how we've tried to translate some messages about climate change into messaging to the public and providers. I think a lot of what we want to get out there, particularly with a disease that's not well known, is the idea that it's increasing and that it's expanding to other areas, and that because of climate change, this might happen. So I think there's two things that we really try to get out there, at least for valley fever. One is trying to prevent exposure. So letting people know where it exists, where it's expanding to, including with the effects of climate change, specifically trying to get the message out to vulnerable populations who are at increased risk. As I mentioned, African Americans, also Filipinos, are known to be at high risk of severe disease, outdoor workers, making sure our messaging is translated into Spanish, since we have a high proportion of Latinx cases. But also at the same time, exposure is really difficult to avoid for valley fever because you're breathing in the outside air. So we put out recommendations about reducing dirt and dust. But we also are really trying to get the message out there to just, like our website is called, Could Be Valley Fever, that if you have these symptoms, think of this disease, if you live in these areas, and if you have these symptoms, and especially if you're an outdoor worker or had exposure to dirt or dust. So trying to just get the message that this is becoming an increasing concern if you have something that's respiratory, even if it looks like other more common things. And that message is also important for doctors who may not think of it right away. So I think for us, it's really focusing on it's increasing, it's expanding, partially due to climate. That might keep happening. Keep this on your radar and think about it.
Yeah, and I think from the mosquito-borne disease perspective, I think a lot of the same insights ring true of, we depend on people going to the doctor in order for cases to get reported into our system and for us to even see them. And so providers have to be looking for it. And with travel associated with dengue specifically, which is surging right now outside of the country, we see higher risk of, cases coming in, looking for the travel history. But when there isn't travel history, then it gets really tricky. Doctors may not think to test for it. And so I think raising physician awareness is really crucial for dengue especially, but mosquito-borne diseases in general. And we have a great some great resources for fighting the bite, preventing mosquito bites, sort of individual protective behaviors using insect repellent, things like that. So those are kind of the best things that we can do to prevent mosquito-borne diseases in the population.
Yeah, we do see public service announcements on fight the bite. Sarah?
Yeah, I think from the Legionnaire's disease standpoint, and yeah, I think this is kind of similar to Cooksey, or valley fever. There really aren't a ton of, active control measures that we can recommend at the individual level for a couple of reasons. One, again, because this, at least for Legionnaire's disease, it's a fairly low incidence disease, and most people exposed don't get sick. So you're always kind of thinking about balancing the messaging to make sure that we're not causing undue fear. There also isn't a ton that individual patients can do outside of their home to reduce their risk. Especially when we're talking about something where like a sink faucet could generate aerosols. That's not something that generates usually the volume of aerosols that we really worry about, but we also want people to still wash their hands. So in the home, we would maybe recommend that people who use respiratory therapy devices like CPAPs, BiPAPs, etc., are making sure that they are cleaning and disinfecting those and maintaining them per manufacturer recommendations, using the appropriate type of water for those. I think often they'll require like distilled or sterile water to be used, right? And not using tap water that may have trace amounts of Legionella in it. So that's something that we think about. And, also I think from the standpoint of things that we commonly see associated with disease, maintaining hot tubs. I mean, that's the classic thing that we think about for Legionnaire's disease, exposure by hot tub. Some people have hot tubs in their home backyard. Make sure that those are well maintained, properly cleaned and disinfected on a routine basis, but also in, hotels, and really businesses taking ownership of that and making sure, that they are keeping those well maintained. And that's, at least with respect to the recreational water sources, that's something that is almost always under the purview of the local health department, where they're going in and they're, doing routine inspections of these devices and licensing and everything like that. So that's not the case always for potable water systems. It's harder for local health departments to affect change at the potable, system level versus something like recreational water. So for Legionnaire's disease, we really do try to really hit the low-hanging fruit, because we do know that spas are dangerous. So for people at risk for disease, I should say.
Okay, Sarah, there's a couple more questions for you in the Q&A. A recent study has shown possible person-to-person transmission of Legionella. Could you discuss that, please?
Sure. I'm not aware of a recent study. I am aware of one historic study that I think the conditions for this were very, very specific, having to do with, I believe, someone who was sick with Legionnaire's disease and also a caretaker who was sort of up close and personal with them. But we really don't think of Legionnaire's disease as, or any of the different conditions caused by Legionella as being transmissible person to person. Although it's maybe been documented in these extremely rare circumstances, we really don't think of it as something that we really need to worry about. It's an exceedingly rare situation that I think is unlikely to come up often.
And another question for you, Sarah. You did mention composting or potting soil as a potential source. Could you elaborate on that, please?
Yeah, so this is another one where it's more rare from transmission. Exposure to potting soil is a rarer form of transmission compared to the traditional water exposure method that we think about for Legionnaire's disease. But as I understand it, I think it simply has to do with the moisture of the soil and the potential for Legionella to still be, aerosolized if you're sort of like digging or gardening or planting. There is one particular strain of Legionella that's more associated with potting soil that is less likely to be detected due to the typical types of diagnostic tests used by providers. So it could be that exposure by potting soil is more common than we currently recognize, but that's another one that is fairly rare, but I like to note it just in case, or just to make sure I'm being thorough.
I'm just curious though, do the normal procedures for disinfecting municipal drinking water chlorination, for example, does that kill the bacterium?
So the way I think it typically works is that there are your settings for municipal water that, there's a certain sort of level of chlorine that needs to be in the municipal water, and free floating Legionella most of the time is going to be managed by that. The issue becomes when Legionella get into the biofilm environment. Because it's more difficult for chlorine or disinfection to affect those bugs if they're in that protective biofilm environment. And so I think with municipal water, you might see trace amounts coming out of a source, but I think you could still have that even if the water is treated as it is required to be treated. So even trace amounts of Legionella can make their way into that downstream built environment. And that's really where you see the amplification occurring. So that's why it's tricky with the prevention measures and how individual buildings really need to make sure that they are, flushing if they're at a higher risk for growth, maintaining aerosolizing devices, etc.
Thank you, Sarah. Here's a question for all three of our speakers. Given the intersection of climate change and the rise in infectious diseases, what are the most effective strategies for demonstrating to decision makers the return on investment of implementing new regulations aimed at mitigating these health risks? And specifically, what data, metrics, communication approaches, which we've already touched upon, have proven successful in making a compelling case for the preventative measures?
So I can take some of this for valley fever. I mean, I think this is a challenge, and we are always working on this, especially for diseases that are not super well known. So for valley fever, unfortunately, and I think this is for maybe the other diseases as well, we get really limited information on the cases that come in. So our regular surveillance data mostly gives us numbers. So we do try to report out the numbers of how many cases, if it's increasing, where it's expanding. But I also think that we have realized that talking about severity, the impact on people's lives, the impact on the work system, and if we can use any kind of cost measures in there can be helpful to get attention. So for valley fever, for example, we just finished a project where we interviewed over 400 cases, and we asked them about how long they were sick, or how many were hospitalized, did you miss work for how many days, trying to get some of those measures. And in addition to that, there's also, luckily, another state department makes an administrative hospital data. So it's technically billing data on all the hospitalizations in California. So we regularly analyze that for valley fever so we can talk about not only hospitalizations, but it has data on the charges for those hospitalizations. So we can put a dollar sign on this is how much it was charged for valley fever hospitalizations in California in these years, or for Legionella or West Nile, whatever it is. And then finally, I would say death data, really talking to how this is impacting people in California, and the financial piece is some of the angles we've been trying.
Thanks, Gail.
I think from the mosquito-borne perspective, what this question raises for me is the value of the local vector control agencies. And those are funded at the local level, often through counties, but they're special districts. And fortunately or unfortunately, mosquitoes, beyond being carriers of disease, are pests that people don't want in their backyards. And so the mosquito control services that these agencies provide, I think, is highly valued by the communities and has the added benefit of preventing disease. And that's particularly true for the invasive Aedes mosquitoes, which I think prevent a lot of people in California, or maybe not prevent, but make hanging out in your backyard in Southern California a very unpleasant experience during certain times of year.
And I'll just mention briefly for Legionella. I think this is something that we haven't fully figured out yet for Legionella. As I mentioned, compared to a lot of other diseases covered by the Infectious Diseases Branch in particular, it's a lower burden disease, and so it's difficult to prioritize prevention of Legionella given sort of all of the many other competing interests, and also just not really having a ton of resources to do prevention. And this is true both at the state level and also at the local level. Unfortunately, where we're at with Legionnaire's disease now is that it's often a little more reactive. So outside of healthcare facilities having water management programs, there isn't a lot of sort of proactive prevention work going on due to lack of resources. And so I think we've seen outbreaks that have gotten a lot of media attention that gets people a little bit more interested over time. But that's not the way that we want it to happen. We want to have the resources to do the prevention before and not necessarily have it result from bad outbreaks. But yeah, we're still working on this for Legionnaire's disease.
I'm curious about, we heard a lot of really good information on the diseases that your talks highlighted. I'm wondering though, and maybe this is a question for Duke, what other infectious diseases are out there that the health department, are on the lookout for, because we could see a rise in incidence as a result of climate change, warmer temperatures, variable precipitation, extreme events, and so on.
Thank you, Carmen, for asking that. I was going to comment, give a few comments as well to the previous question that Rick raised. It's a combination. There's several questions actually combined into one. So we are in the process in my branch looking over all the diseases, infectious diseases that may or may not be affected by climate change, and trying to make the association. That's what we're trying to do. And you see three good examples here that we have done work on and shared with you all. There are diseases, particularly, for example, Vibrio infections. It's another bacterial infection that the bacteria grow in seawater. And people can be exposed by eating oysters, raw shellfish, or taking a walk and dipping their toes in the beach. If they have a wound and they're at risk, they could get a severe infection. All of those are infected by climate, and there are other diseases we're looking into. So our job is basically try to make these connections clarify as much as possible so that decision makers can see that and how we all see how human health could be affected by climate change. In terms of regulations and what metrics, communication approach, et cetera, I would say that we are or have been using the tried and true approaches that we do for all infectious diseases, which is to try to collect as much information as possible, analyze the data, and identify high-risk population, get our communications out to them in terms of what prevention they can do, if there are any, because sometimes they're so new that we don't have any, recommendations. For example, right now, we're dealing with H5N1 influenza A, which is, in poultry, wild birds, and also dairy cows. It's so new that we're still working on all of that. My branch is not responsible for that. We are participating in the state response. And whether this has anything to do with climate change is another issue. But when it comes to what we do in infectious diseases in the center, we focus directly on what to do, what to recommend to the people affected, the high-risk populations. We defer climate issues and how to address that climate and regulations about that related to these diseases to decision makers that are higher up, or people who can pull it all together and make a strong case about that. But for us, in terms of what we do, we have tried and true approaches, traditional approaches that we already have in place. If we see a need for new regulations, we'll propose it. But otherwise, our work is outward looking directly for the people involved and the populations at risk. And so getting back to comment to other diseases, we're looking into that, and maybe in the future we can share more of those diseases with you.
Thank you. Thank you so much. Seeing no other questions, just double checking here. There's one more. We probably have just a couple of minutes for this. Any thoughts, and you may have already addressed this, anything further that you'd like to say on how other state agencies and local government can support these broader public health resilience considerations? So yeah, we have a couple of minutes for responses.
One example I can give for valley fever that we've found helpful in some of the outbreaks that we've investigated. As I mentioned, it impacts outdoor workers. And we have found that a lot of times that's construction projects, and those have to go through local planning departments. And from what I can understand, a lot of that, the regulations and the rules are very locally based. For example, we've had an outbreak in San Luis Obispo, and then I believe in response, the local planning department added into some of the conditions of approval for construction projects that they have to consider valley fever and dust mitigation strategies. And that's such a great way to not only try to hopefully better protect the workers on site, but the surrounding communities. So I think local planning was one really great partner that we discovered along the way that can help in that specific area of trying to reduce risk of valley fever.
Thank you. And Duke, if you'd like to just add on some thoughts to that question before we wrap up.
Carmen, you're asking me?
Oh yes, I don't know if this is an old chat from you.
Well, I think the key is communication and collaboration, as Gail had alluded to. Every time we look into a disease and we find out the other groups, programs, agencies that are affected, we try to get everybody together and talk about it and say, "Hey, this is what we found. Can we do something about it together?" So, and then they can decide what resources they have they can bring to the table to help address the issue. But again, it's another tried and true thing that we need to seize, communication, collaboration, coordination with all our partners, depending on the disease and depending on the people affected. So with Legionella, for example, we may have to someday work with building people, managers and such, and we will be getting into that more and more. So anyway, I think that's the basic that we will need to continue doing.
Thanks, Duke. Yeah, thank you to our speakers, Andrea, Gail, Sarah, and Duke. Yeah, a final thank you to Duke and our colleagues at CDPH for helping us put on this morning's webinar. And finally, please join us for our next webinar, co-hosted by the California Department of Fish and Wildlife, where we will be featuring speakers addressing the impacts of climate change on California's wildlife and actions underway to address those impacts. With that, thanks everyone. We will have a recording of today's webinar available on the OWIHA webpage within a couple of weeks. We'll be notifying the participants. Thank you.
Thank you, Carmen.
Okay, bye.